Maggie Moran. I'm the Senior Vice President for Marketing, Contracting, and Community Relations at Walden Behavioral Care. And it is my distinct pleasure to introduce my friend and a very good friend of Walden's and colleague, Dr. Christina Baker. She is our next speaker. Christina Wood Baker is a clinical psychologist who has been working in the field of eating and weight disorders since the early 1990s. She received her doctorate from Yale University, where she studied with Kelly Grinnell in the Yale Center for Eating and Weight Disorders. Following graduate school, she participated in postdoctoral work at Harvard Medical School, based at the MGH Weight Center. She worked with patients with severe obesity and did research on the impact of gastric bypass on reward-based eating and binge eating. For the last 6 years, she has focused primarily on clinical work and was based at the MGH Adult Eating Disorders Clinical and Research Program until 2010. She has recently transitioned to private practice and continues to collaborate on writing and research projects with colleagues. She has been acting as a consultant for Waltham Behavioral Care, and are we really happy about that? On several clinical initiatives, including its binge eating disorder intensive outpatient program since 2010. It is my pleasure to introduce Christina Baker.
Hi. I hope everyone is still somewhat awake and ready for another hour. I'll try not to go the full hour and a half, keep you too long. So it's great to be here. This is an interesting topic that was handed to me and developed out of really kind of a lot of conversations that I had over time with people at Walden and with colleagues. And a lot of questions often have been coming up more and more about how to handle issues of weight, weight goals, intermingling people of different weights in treatment. As more, partly I think as the BED criteria became formalized and more people presenting for treatment, a lot of the folks who are coming in with BED are overweight, and so these issues are coming up more and more often. So it's an interesting topic because it's not something where there's kind of an obvious way to approach how to talk about this or what's important to talk about. So it's a little bit of a hodgepodge of different things that I thought would be helpful to think about as clinicians. And just kind of bear with me as we go through it. You'll see there's a couple different sections, and hopefully each of them will be interesting and helpful for you guys in your own right. Feel free to put your hand up and interrupt me as we go if there's any questions. I want to give you one little piece of information about me to start with, which is, Maggie mentioned it. The idea of writing a talk on how do you integrate eating disorders and obesity was kind of unusual for me to step back and think about how would I present this to other people, because my training, if you consider my graduate school as kind of like where I grew up professionally, I grew up in a house where eating and weight disorders were always intermingled and talked about the overlap, the distinction, how one informs the other or harms the other. Because I grew up in a center with Kelly Brownell was my father in this situation, and he always came to he developed this center called the Yale Center for Eating and Weight Disorders, and it umbrellaed anything related to eating and weight. And we had groups for obesity running next to groups for bulimia and individual group, all kinds of things mixed. And so it's always been that way for me. So it's a little bit funny for me to step back and try to present this as a question, different questions to you guys. So if there's anything that I'm making assumptions about, please raise your hand and interrupt me. So I'm going to start by just talking about what is the relationship between obesity and eating disorders. And it goes without saying, but I'm going to say it anyway. Obesity is not an eating disorder. It's an imbalance of energy intake and excess weight, but it's not an eating disorder. And it's just important to kind of make that explicit. I'm going to look at, so the other value in the house where I grew up professionally was always to start with the data. If it's not there, you have to muddle your way through. But always have your feet grounded in the data. And so what I did in thinking about presenting this information to you was I basically thought, what is their data on? Because if you do a Google, or not a Google, a lit search on obesity and eating disorders overlap, or treatment, obesity and eating disorders, you don't get much. And I had to kind of think about ways to look in the literature for information that would guide us that were a little unusual. But I started with the data. I'm going to talk a little bit about integrating people of different weights in treatment. Nothing that I could find written about it, so it's going to be kind of just my thoughts about it, and I actually will kind of call on you to, I've asked a lot of clinicians here already what their thoughts are and their experiences on mixed groups, and we'll talk a little bit about that, but I'd love your input because there isn't a lot of guideline, but I have some thoughts about how to think about it. And I'm going to finish because with talking about something that we started talking about it this morning. Cindy Buick talked a lot about this issue of weight stigma. And if you are working with individuals with obesity in any kind of treatment setting, there's a couple of reasons, not just your own bias, but there are a couple of reasons why it's really important to be aware of the impact of weight stigma and to think about how it might be affecting patients and the people around them. So you can see, it's kind of a little hodgepodge, but it's going to be fun. Okay, so traditionally, these two fields have been pretty separate. When you look at research, I'll show you some images here. Typically, the research has been done in separate journals by people in different fields. Clinical protocols have been pretty separated. Health promotion efforts have been separated. And in many ways, people came kind of to the obesity world with thinking about it as a biological, as genetic, from a medical perspective, whereas the eating disorder research and health promotion stuff has often come up more from a psychological background. But there are many things that they share, and so it makes sense for there to be, as I kind of experienced in my training, for them to be in the same space in terms of thinking about commonalities, shared risk and protective factors. Increasingly, there's so much data coming out about the biology of eating and weight that crosses over, from weight to eating disorders. There's some, literature on ghrelin and leptin being implicated in both. There's certainly a lot of research on reward and the dopamine system and how those, there are ways in which those systems are certainly at play in both eating disorders and overweight. And the last thing is, we're going to come back to this a couple times, and it's something that always seems so second nature to me when thinking about these kind of distinct entities and how they might cross over, is the treatment goals for obesity and for any eating disorder are essentially the same. What are you looking to get them to? And we'll spell that out later, but we're pretty much headed to the same end game. And so it makes sense to think about, from a treatment perspective and for prevention efforts, to think about ways in which they might overlap, given that they do exist together in certain individuals, and the fields have a lot to learn from each other. So increasingly, as was brought up this morning, there's a lot of attention on obesity and childhood obesity, prevention of childhood obesity. And one thing that's been good that's come out of this is that as programs are looking at prevention of childhood obesity, it's increasing people's concern that having a lot of focus on weight and body size, you heard the story about being weighed, in the school, that is actually going to trigger eating disorders for some kids, that it's going to increase eating disorder symptoms. What this has done is actually kind of gotten a lot of researchers and people in the field to be saying, hey, we've got to work together. If we're going to be trying to prevent obesity, and we're worried that this is going to increase eating disorder symptoms, we have to work together. And so there's actually been kind of a cool cross-pollination that's developed out of what, is potentially kind of a not positive outcome. So the question here is, does dieting in youth cause eating disorders? And we're going to come back to that. That's one of the big questions. So people basically here, I'm just saying, there's an increasing call for kind of people to work together to send complementary messages to parents, children, and school. And it's allowed for a lot of discussion for researchers and clinicians from the two kind of coming from separate areas of obesity and eating disorders to kind of cross over. Okay, so I just want to talk about what is the relationship between obesity and eating disorders. Does obesity come first? Do eating disorder symptoms come first? It's one of my favorite cartoons. And there's data for both. So there's some, for instance, Chris Fairburn did some big studies looking at risk factors for both binge eating disorder and bulimia, and it found that for both, childhood obesity was a risk factor. We know that overweight teenagers, compared to their non-overweight peers, are more likely to develop or engage in unhealthy dieting practices. On the other side of things, we know that people with binge eating disorder are more likely to be overweight, and increasing kind of the greater binge eating is associated with higher weights. We also know that kids who are dieting or using unhealthy practices in adolescence actually have a higher chance of gaining weight relative to their peers who are not dieting, and we'll talk about that a little bit more. But so they can go both ways. And my contention is that it changes over time. These are two extremely heterogeneous groups. You can't really make generalizations. We know they're multifactorial in terms of the etiology. And different, eating, weight can go up and that can affect eating, and eating can change and that can affect weight, and it becomes, a complicated relationship between the two. But the one thing that we can go back to is that regardless of kind of, chicken or egg, there are shared treatment goals. At the end of, if you want to think about kind of your treatment endpoint, we would like anyone coming in with either an eating disorder or obesity to end up eating healthy, moderate meals, having healthy, moderate amount of physical activity. This is so common sense, but I'm just going to say it. And stability of other health behaviors. So, it makes sense, right? If your end game is the same, that you could be thinking about potentially treating people without it being a problem in the same, treating both things together. Some of you may think, no, that's not right, but we'll get there. Other outcomes that you want that are shared: physical health, quality of life, improved mood and psychological health, and something around weight loss, prevention of weight gain. Okay, so the most common client that you would see where these two things intersect are individuals with binge eating disorder who also have obesity. So that's what we're going to focus on because it's the most common. So we know that binge eating disorder is associated with overweight and obesity, and individuals with obesity are at higher risk for developing binge eating. However, they are distinct, and it's important to remember that most individuals who are overweight are not engaging in recurrent binge eating. And I'm going to show you it's not a perfect image, this is not done with numbers, but just a general idea here that about 20 to 30% of people seeking treatment for their weight also have binge eating disorder. So that's, is there a little pointer? So this, it's not, it's a small piece. If this is obesity and this is binge eating disorder, it's a small piece, or about a third, a little less than a third. It depends how you assess the binge eating disorder. It's also important to note that in these studies where you're getting the prevalence data, people are seeking treatment for weight loss, so it might be different if they were coming in for eating disorders. So most people with obesity do not have binge eating disorder, but approximately 2 out of 3 people with binge eating disorder have obesity. And the prevalence of BED increases as the degree of obesity goes up. So if you're working with individuals who are really at pretty extreme high weights, it's important to assess for binge eating disorder. Okay, so one way to look at what is unique about these individuals, the people that in that previous slide are in the overlapping circle, people who have both obesity and binge eating disorder. We know that there's some unique characteristics of this group as distinct from individuals who have obesity but do not have binge eating disorder. So I'm not going to go through each one. You can kind of see. The general picture here is that they have more distress, worse quality of life, more impairment. They also have some unique things to their eating in that they have an earlier onset of obesity, their weight gain pattern tends to be quicker, they tend to consume more calories at regular meals, and binge eating is associated with more weight cycling. And the little note at the bottom is just a lot of research is either adolescent or adult, and this just shows you that it's similar for the adolescents. Okay, so there are kind of two treatment targets when people come in, right? If someone comes in with binge eating disorder and obesity, it depends if they're coming in to which kind of center, perhaps, what they identify as their treatment goal, but almost always there are actually 3 treatment targets. Almost always you've got obesity, binge eating disorder, and some kind of mood component. So where do you start? Do you start with one, with both? Which one? Does it depend which center? If it's a weight center versus an eating disorder center. I'm going to assume that most of you are going to be, maybe I shouldn't assume this. How many of you would be thinking about this from the perspective of, I'm an eating disorder clinician and someone's coming in with both? Is that most of the audience? Not a weight center. Is that right? Okay, so we're going to think about it mostly from the perspective that someone's coming in and to see a provider or a treatment program with an eating disorder and they also have obesity. What happens? What do we do? Okay, so some people will argue in the field broadly that you should treat the obesity first. It's a huge public health problem. It has a major impact on people's health, and it's something that has a huge impact on their quality of life. They will also argue, if you're on this side, that treatments for obesity are less expensive and shorter. On the other side, we'll argue that if you reduce binge eating first, weight loss might follow. Trying to lose weight will trigger eating disorder symptoms. And, big one, obesity treatments don't work, so why bother? Okay, so there's a lot of debate. Does anyone actually those are the ones that are written up in the literature and that I was thinking about. Does anyone have any other thing that they would add to the debate?
I would add that at first it's a malnutrition issue to begin with, so whether it's from one, in my opinion, whether it's on one end of the spectrum or not. So I really don't see these as separate issues. I see them as looking at the nutrition first.
Okay.
Where is that person, regardless of their weight? Because we also do know that a lot of people who are obese may be bulimic and they may be eating less than 600 calories.
Right, so you would say, look at the behavior, and actually what you're saying supports what I said before, that the treatment goal is the same. Just get them to the same endpoint. It doesn't really matter kind of how you define it. It's more just looking at the behaviors and getting to working towards the endpoint.
From a nutrition
sense.
Not a weight sense.
Right, right. Okay. Anyone else? Oh, sorry. Go ahead.
Well, I've often heard from ED clients kind of the opposite of trying to lose weight, the trigger ED of, if I lose weight, then, my body will trigger binges as much as I'm so unhappy. So
Okay.
I should lose weight first.
Okay, so they might argue to you that if I lost weight first, I'd stop binging because I wouldn't be unhappy anymore.
Yeah.
Yes, okay. Okay, oh, yeah?
I was just going to say, I actually asked one of the people's question similar to this at the end of her lecture, because I have a patient who is overweight and bulimic, so she's a little bit different spin on this, but I asked her, because she talked about the weight loss and how, we need to shoot for a higher end weight, and she said she absolutely has to stop the vomiting. She has to work on the bulimia first before we can work on the weight loss.
Mhm.
And that was kind of her, there was no wiggle room.
No wiggle room on that. I did not look at the data on bulimia and weight loss, but I'm going to present you a bunch of information about binge eating disorder and weight loss and whether the order matters.
I don't think the goals are necessarily the same, because the patient often comes in with the interest in losing weight, and part of our job might be the
Right.
The historic norms.
Right, beautiful. So one of the issues is that comes up in the decision of what to do for treatment is what are the treatment goals that the patient has. So that's a huge point of what we'll talk about. So that's right on target. One of the things I just want you guys to keep in mind, you've probably thought about this, is that they get mixed messages a lot. Yeah, my son found this. He loved this. I thought this was fun. It's particularly, it's important to know that this is kind of what patients might be hearing, particularly if they're from a primary care perspective or they go into a weight center, they're being told it's very important that you lose weight, and they're certainly telling themselves that. But, and I've heard this over and over and over again through the years and in articles, don't try to diet because it might cause eating disorder symptoms or a relapse of your eating disorder symptoms. That's a pretty common belief that's out there. So we're going to look at this. We're going to look at 4 assumptions. 2 of them are kind of related, but I wanted to separate them out, that sometimes I hear around and are in the literature. So one is that weight loss shouldn't be a goal or focus of treatment for someone presenting for ED treatment for BED. So if they come into you and they say, I've got binge eating disorder, you do an assessment, you establish the diagnosis, and they say, and I really want to lose weight, you need to say, nope, that can't be on the table. You have to treat your binge eating first. So we'll get to the idea of talking to them about their goals and meeting them where they're at. That's a clinical decision, and we'll talk about the value of that. But this is taking the stand that some people believe that you shouldn't allow weight loss treatment until the binge eating has been treated. Related to that, binge eating must be treated psychologically before any attempts at weight loss. So for anyone who's already had an eating disorder, recommending or imposing a diet or a calorie reduction meal plan will trigger binge eating. Third, weight loss treatment won't work if someone is binge eating, so why would you do it anyway? And third, if a client stops binge eating, she'll lose weight, or he'll lose weight. So treat the binge eating and now the weight won't follow. So have you guys heard these before? Are these kind of familiar assumptions, beliefs? Okay, so we're just going to go through them. And it's, as it is with most data, there's a lot of messiness, and it's a little bit difficult to pull a complete, full conclusion. There's not consensus, but there's some pretty helpful stuff to look at. Okay, so we'll start with the first one, which is obviously related to the second one. So the idea that you can't have weight loss as a goal gets back to what she mentioned over there, is that you may not be able to help it. So you can tell that patient, nope, we're taking that off the table, and that's not going to be part of this treatment. And you very well will fail at convincing them of that. You can try, but it's very important to find out what their implicit goals are. And they may say, I'm here for treatment of my eating disorder, but you have to talk to people about what their expectations are about weight. And if they say, I do want to lose weight eventually, but I truly, truly am here for the eating disorder, that's great. Then you can focus just on the binge eating. But most individuals have an implicit desire to lose weight. And I think it depends on where you're seeing patients and the level of severity. But I have had many people come in and who have binge eating disorder, and weight is not explicitly stated as a goal. And then kind of 4 or 5 sessions in, there's great discouragement and signing on to a new, one recently was, I've got 6 weeks, I bet my brother-in-law $10,000, and if I'm not down 25 pounds, I'm at $10,000. And that was after a bunch of sessions with me about lots of stuff that I thought might have helped avoid that kind of goal. And that was someone who didn't come in to lose weight. They came in to get a handle on their eating that felt out of control. And it's there, and it's really important to assess it. So what's there is the desire to lose weight. So it's often a high priority, and the other thing is that it's very important to think about this assumption that if I stop binge eating, I'll lose weight. Because I think what happened in the case I just described is that the assumption was, well, if I get my eating under control, I'm going to lose weight. And then 4 sessions in, you kind of said, my weight's not moving. And I said, well, we weren't talking about your weight. That wasn't kind of on the table. We haven't cut your calories or talked about that or anything about your eating. We're just talking about normalization of your eating. And so it was discouraging. And he, I think he thought about, is this the right treatment for me? So the other thing to think about is the importance of including weight as a goal. Is it kind of ethical of us to not address it? So it comes back to, and I don't have an answer to this. It comes back to if somebody says, I don't care about losing weight, but they're a BMI of 37 and they've got a lot of health problems and they just want to treat their eating disorder, I guess, do we say, okay, that's fine? Or as a health provider, do we say, well, would it be okay if we talked about your weight and the importance of that and whether we could make the two work together? Right, so it's just something we have to think about because it is a big health problem. There are certainly cases, I have no way to give you any definitive guidelines because there aren't any, but there are certainly, we all can think of cases where weight loss goals may need to be delayed. And without anything to guide me, I'd be happy to take your thoughts about it, but immediately comes to mind is major comorbidity of substance abuse or a major mood disorder that really takes precedence or would get in the way of weight loss and become very discouraging. Or if you think that the focus on weight loss would not allow them to do the normalized eating that would help them recover from their binge eating disorder. So there are going to be case-by-case situations where, it really kind of upfront maybe should be off the table. Does that make sense? Okay, so I want to look at this question of that you have to treat binge eating before you can try losing weight. And there are a couple of ways to come at this. The first one is to look at, does dieting put someone at risk for eating disorder symptoms? Most of this literature is done in teenagers. And what they find, let me step back before I get to the data and just say that the critics of dieting, coming from the eating disorder side, would say that it contributes to increased prevalence of eating disorders. It evokes a counter-regulatory response, such as binge eating. It leads to problems with emotional eating and eating regulation. So here we are. Does dieting cause eating disorder behavior? This is what we can find from the adolescent literature. Is that dieting, and I'm going to put it in quotes, that's a clue for what's to come, is that it's associated with increased risk of bulimia symptoms. It's more likely to precede binge eating. It predicts weight gain. And it precedes the onset of eating disorder behaviors for many when they kind of report back. Now there was one big study recently where they asked people retrospectively to report on whether dieting or eating disorder symptoms started first, and a little less than 50% said it did, and so that left actually a little more than 50% who said no, that the eating disorder behavior came first. When you look at adolescent studies that are experimental, where they assign people to a weight loss program, they don't see an increase in eating disorder symptoms. So can anyone think about why that might be? Yeah.
The program you're talking about is not a prescribed diet, but maybe a behavioral intervention, maybe something that might work with mindful eating or intuitive, differentiating hunger from triggers.
Yep.
I'm not sure necessarily there's any evidence to say that that contributes to eating disorder.
Right. So what she's saying is that the experimental studies where you go in and they assign you to a thing, you're getting some kind of treatment, and you would presume that if they put you on some kind of a diet that it would be reasonable. So that leads me to the question of why then are there, why are we seeing, all these increased risks in adolescents who are dieting? So what does it mean, right? That's the big question. And I found some great cartoons just to make you guys wake up and laugh. I like this one. If hopping burns more calories than walking, it helps you eat more salad, then okay, I approve of the bunny suit diet. And if you were to, I was thinking about this morning, and I was thinking about the word diet.
it's such a loaded word and has so much history and cultural variety in terms of what people mean by it. And it actually, in its real meaning, is just kind of, what are you eating? What are you taking in? And yet it's taken on this, if you asked 50 adolescents, you'd probably get 48 different answers. If you said, so what's the most recent diet you tried? There was the banana and milkshake diet and the grapefruit diet and Atkins. Yes?
So is there evidence of the caloric deficiency itself?
We'll get there. Good question. So basically what the researchers were puzzled of, why is dieting causing eating disorders, and actually more puzzled by, why is dieting causing weight gain prospectively? These teens who say they're dieting are more likely to gain weight. Why is that? And so what they did is they kind of pulled it apart, and they asked more specifically about when they were saying, it was a single question about, have you been dieting? Right? It didn't have any clarification in most of the studies. So what they found is that basically most of the time when the teenagers were asked, are you dieting, what they were doing where they were skipping meals, and they were using laxatives, and they were using diuretics, and they were cutting out entire categories of food. That's what they thought of as dieting. And so does that cause a problem? Yes, potentially. Another interpretation is who's in the studies. So one thing they're thinking is that why the dieting is a problem for these teenagers and why they might be gaining weight is that people who are going on a diet already as a teenager may be kind of already fighting a trajectory of weight gain that's going up. And so you may just be seeing what would have been their natural trajectory, and they were trying to kind of halt it. You're also in some of these studies getting kind of normal, healthy individuals for whom when you start dieting when you really don't need to, you may get that kind of energy deficit. And well, actually, we'll come back to that. I don't know that the energy deficit's a problem, but for a normal weight person to be dieting, maybe that does cause problems, whereas for some individuals, it may be that it's the right thing to be doing. The studies are kind of mixing all these people together. And there's just differences in the population when you're looking at eating disorder, dieting, versus what's happening in kind of a normal population of teenagers. So there's problems with interpreting this data, basically. So I'm left not convinced that dieting causes eating disorder symptoms from that. And this was just another one that made me kind of think about how far we've come from the real meaning of having a healthy diet. Okay, so this is what you were asking about, the counter-regulatory response. And I've certainly said this to people. If you restrict, you're more likely to binge. I wasn't technically wrong, but I think I didn't fully understand it until I delved into this. And it was very interesting. So I looked at the biological literature on this, and what they find is that, I'm just going to put them all up here and you can kind of scan through them, that essentially binging behavior, when they kind of try to trigger it in animals, they can get animals to binge eat when they haven't had actual caloric deprivation preceding it. So what they seem to be narrowed in on is that it occurs with deprivation of kind of a high-fat chow, that they call it, but it's not because they've been deprived. They might binge if they want that food and they can't have it, and then they're given it, the high-fat, tasty food, but they don't necessarily binge on the unappealing food, and it's not following caloric deprivation, it's following deprivation from the thing they like, okay? So basically let me just show you on this page. So it's not the reduction in calories that causes a problem. It's perceived deprivation of the thing you want that seems to cause a problem. That's what the biological literature shows.
Non-food related?
Nope. So the way they set up, without getting too into detail about it, with animals, they'll expose them to their regular kind of rat food that's just kind of plain, boring, little pellets, and then they'll expose them to like a really tasty one. And what they find is that if they deprive them from the tasty one and then expose them, then you see binge eating, but they can be fully fed. It's not because they've been deprived of calories. It's because they've been deprived of the food they want. And Garfield here points out the kind of feeling of like, when you're in that mode of deprivation, how awful it feels. He's dramatic about it. Okay, so let's look at this from another perspective. If you have someone who has binge eating disorder and you put them into a weight loss treatment, does it cause a problem? This, to me, seems like the best place to look for answers of if someone comes to you and they have binge eating disorder and obesity and they say, I want to do both, can you, should you, is it unethical, is it going to cause a problem? So, essentially, the takeaway is that professionally run weight loss programs don't seem to increase symptoms of eating disorders. And I've pulled a few here for you to see that there's tons of studies on this, but it can be a very low-calorie diet, it can be a pharmacological intervention, it can be behavioral weight loss therapy. They don't see increases in binge eating in response to these interventions. Yeah. Right. Well, most studies are maybe 12-month follow-up. Maybe. But some of them, I think, go out 2 years. Some of the behavioral weight loss therapies go out 2 years. I'm not sure about the very low-calorie diets. So the takeaway, well, let's go to this one first. Sorry. This was a good study and recent. It was a comparison of CBT, behavioral weight loss therapy, and CBT followed by behavioral weight loss therapy, because I think one of the things people naturally think is, well, okay, if we're not sure, why don't we treat the binge eating first and then follow it with behavioral weight loss therapy, and that kind of might be the best progression. And they, yes?
Can you define behavioral weight loss therapy and how it differs from CBT?
That's going to be my next point. Beautiful. Okay, so basically what they see are comparable effects on all kinds of things, and there have been a lot of studies on this, comparing behavioral weight loss therapy to cognitive behavioral therapy, because of this whole debate in the field that goes back, where people were saying, you've got to treat the weight, and other people were saying, no, you've got to treat the binge eating. And so, these fields, and it was often scientists arguing about it, and so they kind of just got into doing these studies on the more easily studied scientific therapy of CBT and behavioral weight loss therapy, which is, I would compare it to maybe regular eating. Like, I don't want to compare it to a program because people have different ideas about the programs, but behavioral weight loss therapy is just a standard, cut back your calories. I don't know if they give them meal plans. I don't think so. But it's a pretty just standard, eat 6 times a day, be careful, look at different balances. It's a pretty standard behavioral weight loss program. And they found no advantage of sequencing the treatment, of doing the binge eating treatment first, followed by, let me go back for a second, followed by the weight loss. One thing that they always find in the studies is that with CBT, the binge eating, if you look at the graphs, the binge eating goes down quicker, and with behavioral weight loss therapy, the weight goes down quicker, but they kind of end up at the same place, going out 6, 12 months, and the effects kind of continue to happen after the treatment has ended. So the takeaway from these studies, and we might have some questions about this, but the general takeaway is that binge eating should not be a contraindication for doing behavioral weight loss therapy. So if someone comes in and they want to focus on losing weight, and there's not data to really say you absolutely should not. Now, the question that was brought up is so obvious that the CBT treatment for binge eating disorder is essentially, if you look at the regular eating page of the book, it's make sure you eat every couple of meals, eat breakfast, lunch, dinner, 2 snacks, maybe dinner, eat moderate amounts. It's exactly what you would recommend for someone who's trying to get their eating regular in behavioral weight loss treatment. I guess maybe the only difference is a behavioral weight loss program might have a little more focus on amount, whereas the Fairburn CBT model doesn't talk about amounts or types of food. It's really focused on the schedule and regularity. But you can imagine that's been a very effective treatment for binge eating disorder, just regular eating. You can imagine how that would influence someone's weight, ideally, right? So it's not necessarily off the table to have weight as a goal. That's my main message. Okay, so now the summary of that: no evidence that it's a bad idea or that it will precipitate binge eating. And promoting weight loss in adolescents doesn't increase risk of eating disorders in overweight children. That's if it's done well. So that's the key, is if it's done if the weight loss focus is healthy and minimizes perceived deprivation. So this comes from a fairly recent kind of overview of all the literature from the obesity field, because people were worried about, is the focus on childhood obesity prevention triggering eating disorders? Okay, so now let's look at this next assumption, that weight loss treatment won't work if someone's binge eating. And the summary is that individuals with obesity and binge eating respond similarly to weight loss programs. So this gets more complicated. There's so many different questions to be asked, but it basically, somebody at baseline enters a weight loss program, and there's studies on a variety of different kinds of weight loss programs. It doesn't mean they are going to have a worse outcome. It doesn't mean that they're not going to lose weight as quickly or as much. So there was no differences in behavioral weight loss therapy in the amount of weight loss between a group with binge eating disorder or without. There was a kind of mail and phone study done recently, and there was no baseline binge eating, did not predict any differences in outcome. With a very low calorie diet, they found overall weight loss the same, the rate the same, and the weight regain the same. Unfortunate. However, there's some caveats. There are some studies, I'm summarizing the positive ones. There are more that are positive, but there are some that find a negative impact of binge eating on weight loss. And in the very low calorie diet studies, they find that binge eating is associated with larger lapses in adherence and quicker weight regain. They end up similar, but it happens more quickly. And you got to wonder, that might be emotionally not a good thing. Binge eating may be a risk for weight regain if it persists with treatment. Okay, so this is the sticky part. If you go in to weight loss treatment and you have binge eating disorder, you are not at you're not at a disadvantage in terms of losing weight, similarly to the other folks in there who do not have binge eating disorder. And oftentimes that weight treatment will improve your binge eating disorder. If you have binge eating disorder at the beginning and you do the treatment and your binge eating disorder does not get better, you are at higher risk of weight relapse. So it's kind of a funny thing. It's basically like, if it works for your binge eating disorder, then you're not at a disadvantage. But if it's not a good match for treating your binge eating disorder, then yeah, your binge eating disorder means you're not going to do as well.
Maybe it's simple way to look at it, if there's an underlying emotional trigger for binge eating as opposed to a nutritional trigger, maybe that would differentiate who has a better outcome versus not.
I planted these people in the audience to just foreshadow what you need to know. Yes. So, and we'll talk about that exactly. One thing though is that there, in a couple of the studies, that task force that looked at these studies did find that these folks with binge eating disorder who were in weight loss programs and who went well also had improvements in mood and anxiety. And probably any kind of behavior therapy that you're doing, we know it translates. You're kind of teaching a set of skills in CBT that people can use across domains. So if you're in a behavioral weight loss program that's looking at triggers and mood as a trigger, you're going to be getting some, probably a little bit of advice, or at least prompting you to think about how might you respond to your mood differently than binge eating. So I think you're getting that we're going to come back to the fact that for some people, I think you're right, that this treatment, the weight loss treatment is not going to work for their binge eating disorder, so it's not going to work for their weight, and they may need something different. Okay, so baseline binge eating, not necessarily a predictor, but that's contingent on the fact that the binge eating gets better. Okay, last one, and this has been out there for a long time, wandering around the eating disorder and obesity kind of literature. If a client stops binge eating, he or she will lose weight. What do we think? True? False? Sometimes, like the in-between. There's no evidence that available binge eating treatments lead to weight loss. So it's funny, because we know that binge eating causes weight gain. It's associated with higher weights. More binge eating is associated with being at a higher BMI. And yet the treatment for binge eating, it's often mysterious. You're working with a patient who's binging a lot, and they stop binging, and their weight doesn't change. And honestly, there's not a great explanation in the literature. You know, one thing that I've heard or read is that the binge eating occurs against a backdrop of general overeating, and that some of those calories just end up getting mushed into general overeating, and so it's still, you know, you've stopped the episodic kind of out of control eating that feels bad, but there's still an excess of calories. There's also, going back to what we talked about at the beginning, this group of individuals who have both binge eating and obesity, they have higher rates of comorbidity, of depression and anxiety and great distress. And a lot of them are on psychotropic medications, and not all, but some psychotropic medications can, in some people, induce weight gain. And when you take them off, unfortunately, we don't see a decrease in the weight. So it's possible that there's some component of this for some of these folks that's medication related, but essentially there's not a great answer. And oops, I don't know why that went, oh, there we go. So the two kind of pluses, though, are that oftentimes it will stop the trajectory of weight gain going up. And that's critical, right? So that's a winning situation if you do an intervention with someone and they reduce their binge eating and their weight was on a trajectory up and it stops. That's a great outcome. And abstinence of binge eating, so I talked about that after a weight loss program or just in general, even if you didn't do a program, but abstinence of binge eating is associated with weight loss maintenance. That's true also in the bariatric surgery literature, that binge eating, there's all kinds of debate, should people with binge eating disorder have bariatric surgery? And the data's been really messy on that, partly because you can't really assess binging after surgery because they can't eat a large amount of food most of the time. It's complicated. But essentially, if you have binge eating before bariatric surgery, it's not necessarily a predictor that you're going to have a problem later. But if you're still binging after surgery, then that's going to be a problem for your weight. So it's kind of the same answer. Okay, so I wanted to get back to your point here. This is, I think, a useful thing to have in your head when people come in with binge eating disorder, is there have been a couple of studies that have looked at kind of subtyping the population because people felt like it's pretty heterogeneous, and were there ways to kind of simplify it and that might help with prediction of treatment outcomes and decisions about what to do for treatment. And a couple of studies have replicated this. Carlos Grillo came up with this, through a cluster analysis, these two subtypes. One being dietary, exactly the word that you used, and the other being dietary negative affect. And I think it's 2/3 a third when they break it out. And so this second group, maybe this is a group we think about differently. Maybe if there's more of a dietary dysregulation, doing weight loss along with the kind of CBT treatment makes sense. And then maybe for these folks for whom there's a lot more comorbidity and distress and emotional component to their eating, maybe they should have a different path. And so I'm just going to throw this up there as, this is, I don't know why it got off there, sorry. But, one thought here is that you assess eating and mood when you first see somebody and try to get a sense of whether they would fall into one of these two categories. And you could look at, Carlos Carrillo's kind of the parameters or what he used to assess them. I give them a BDI, and then I give them something called the EDDS, and it gives me a pretty good sense of how strong the mood component is. And then, maybe you could just go for these folks to behavioral weight loss therapy if you're an outpatient provider. I know the folks at Walden, you're probably 99% of the time getting this group, and on the inpatient or higher levels of care. But here, there are some psychopharmacology agents. I'm not going to get into that. But there's also the CBT manual that has been shown to be effective, just as a dietitian or a clinician can give, or even a PCP can give it to an individual, and it can be helpful on its own. And then these other folks, maybe I know the one study came out that said sequencing was not more effective, but maybe it makes sense for some people, right? Maybe it does make sense to start by doing maybe IPT is more appropriate than CBT, in which case you're not really even talking about weight, and it makes sense to wait. So you could see how there could be two different pathways to go, and how it's important to think about, the presenting kind of conglomeration of issues that come in. But either way, I can tell you that either way, you are still going to want to be very clear about assessing goals. Because just because you're not sure they should be doing weight treatment here does not mean they don't think they should be. And so that should be on the table. Okay, so summary, don't be afraid to talk about weight loss because they're thinking about it. Dieting in unhealthy ways can contribute to binge eating for sure. Healthy, moderate approach to weight loss is not harmful, and behavioral weight loss therapy can actually help binge eating, as well as facilitating weight loss, with the caveat that maybe for some people it's not going to work or not right away. And that's the final point. Comorbid psychopathology is really important in the treatment planning. Okay, we're going to shift completely. We are going to talk about, does anyone have any questions maybe before I move on about this? I mean, I think we've kind of hammered it home, right? It's okay to talk about weight. For some people, it's good to have it on the table. Don't be scared about that. It's not necessarily going to cause problems. Okay, so the next thing I want to talk about is I work with folks at Walden and talk with colleagues, and sometimes one of the things that seems problematic is how is it ethical to have folks with anorexia and overweight binge eating disorder in the same treatment setting? Can you have groups where they overlap? Is that something that people have thought about or that's come up for some people? Yes, okay. So I'm gonna propose that oftentimes when we are thinking about that, we're coming at it with this mindset of we've got these folks that are eating too little and are very thin, and we've got these folks that are eating too much and are overweight. How are we going to put them together? That's going to be really difficult. And I'm going to propose that we think about it differently and think about it that neither group has a healthy, balanced relationship with eating in their weight, and so they can be in the same place. There are challenges, but there's opportunities as well. And as I was researching this, I came across a book that Hilda Brooke wrote. Everyone knows Hilda Brooke, way back, kind of one of the first people to write about eating disorders. So she published a book over 30 years ago called Obesity and Anorexia, I think, one or the other. And basically, she conceptualized them as they are both disorders of hunger and appetite and relationship with food. So I thought that was kind of cool that she'd been out there writing about that a long time ago. So here are the opportunities. They have similar struggles. They're using eating behaviors as coping mechanisms, oftentimes have very high standards and perfectionism, and one reason that the BED is so troubling is it's often the one thorn in the side of people who are super successful and have very high standards in the rest of their life. There's often a caretaking theme that particularly I would think, well, we're thinking about bulimia, anorexia, and binge eating and EDNOS all together. Denying their own needs. Everyone needs to eat, even the person who's overweight, who may be embarrassed to eat in front of these very thin people. Self-critical. and overvaluing the importance of weight and shape in how they define themselves, which is kind of the core cognitive feature of an eating disorder. And so one of the main opportunities is what we talked about this morning briefly, is getting to know the person behind their weight. So much of what's going on for both of these individuals, someone who's overweight with binge eating disorder and someone who's underweight with anorexia, is how the overvaluing how much this says about you as a person, and a lot of biases. Generally, they both have biases about the overweight. The overweight person and the underweight person have a lot of negative stigma about weight, and it's a great opportunity to get to know somebody who is overweight in a meaningful way, who's sharing the same struggles as you. If you look at literature on stereotyping and kind of, in-group, out-group stuff, this is the perfect way to try to work on stereotypes, is to put people together with shared goals. Okay, so here I would say are the challenges, but that it's okay for them to be uncomfortable is my preface. These are the challenges that I've heard from clinicians who do this work, and that I've heard from patients of mine who've been in group settings, is that basically for the folks with anorexia and sometimes with bulimia, if they're working with individuals who are overweight, they feel like this is my worst fear, and it's just really uncomfortable. But I love that discomfort, right? I mean, it's basically forcing them to put out there in their head, and you might not talk about it in the group, but individually, what it elicits, and what are those beliefs, and are they valid, and are they worth holding on to, And it's generally gonna be very uncomfortable for them. One, because they're uncomfortable just because they're afraid of it, but two, they're probably uncomfortable that they even have those negative beliefs. So you're basically, the whole goal of treatment for eating disorders is, tolerating the discomfort of lots of different things. And this is just another example, right? So I would say, there's no evidence in the literature, nothing I could find to say, yes, you should have mixed groups, no, you shouldn't. So sometimes you don't have a choice. You have census issues, you have staffing issues, you have insurance issues, and you're in a big treatment setting, and they're going to end up together. This is, if they are, use the opportunity and think of it as a good, a good opportunity for people to kind of elicit some of their cognitions and work on their stereotypes. Okay, so quickly shift gear. This is the last thing. But I think it's really important, and I was really happy that Cindy brought it up this morning. Everybody has beliefs about weight, and it's important to look at them, and it's very important. There are three things that I think are important to think about. One is, what are your own stigmas and biases? Oh, wait a minute. Yes, sorry, that's the second one. First one, what are the stigma and biases that your patients come into treatment with from having navigated the healthcare system as someone who's overweight? And we'll talk a little bit about what they might have come away from their treatment experiences with. And last, being aware of the attitudes of the other clients in the group, right? So you kind of have the potential for a history of stigma to come in, for your own biases and beliefs to come into play, and if you're in a group treatment setting, for the other individuals' biases to come into play. So just a little bit of background, and all of this comes from the Rudd Center for Food Policy, which is kind of the Yale Center for Eating and Weight Disorders, where I trained, moved into becoming the Rudd Center for Eating and Food Policy, and they do a lot of work on weight stigma and weight bias. So this is Rebecca Poole and Kelly Brownell and Marlene Schwartz. So they have a great website with lots of training information and stuff to give to patients. It's really worth exploring. So patients with obesity often feel stigmatized in healthcare settings. They're more likely to avoid routine care. They may indeed receive compromised care. It's pretty crazy, some of the stuff when they do studies. It's pretty upsetting, some of the stuff that providers will say about working with their overweight patients. And you'll hear that from patients. When they're stigmatized, they're more vulnerable to depression and low self-esteem, less likely to feel motivated to make changes, and they may even turn to unhealthy patterns. They did one little study where they had two groups of overweight folks, and one group read a story about weight stigma and the other read a neutral story, and then they put them in a room with snacks, and the group who read the weight stigma story ate a lot more of the snacks. So we have documented weight bias that I'm embarrassed to be in this group, but here we are, we're all in there. It's been documented that it's across all these different specialties. And some of the things that, the adjectives that they've elicited in studies is providers often view patients, I mean, it's so upsetting to see, but non-compliant, lazy, lacking in self-control, weak-willed, sloppy, unsuccessful, unintelligent, and dishonest. We know that these biases exist. You know, children would rather lose an arm than be overweight, just these, yeah. So it's out there and among professionals. Some of the consequences, it increases vulnerability to depression, anxiety, low self-esteem, poor body image, and suicidality. And some of patients' reactions that have been documented, they feel berated and disrespected by providers, upset by comments about their weight from doctors, perceive that they won't be taken seriously. And let me just reiterate, most of you probably do an incredible job of interacting with your patients because you're in this field and sensitive to it. The reason I'm presenting this is so you know what they're coming in with potentially, because not everybody is as careful. Reporting that their weight is blamed for their problems and feeling pretty reluctant to address weight concerns. And parents who are, you know, if you have folks that are overweight and binge eating who come in, parents often feel very blamed and dismissed for the problem. So this part's really interesting. It increases risk of unhealthy weight control practices, chronic dieting, eating disorders, and binge eating, increased food consumption, and probably because it leads to that overvaluation of weight and shape as being so critical to who you are and as being reflective of all these terrible characteristics. So it makes sense that it would, you know, lead to some unhealthy behaviors. So some of the questions to ask yourself, and hopefully we all answer beautifully to these, but just to really be honest, as Cindy talked about this morning, how do I feel when I work with people of different sizes? Do I make any assumptions about character, intelligence, ability, health status, or behaviors based on their weight? What stereotypes do I have? How do I address the needs of obese individuals? And am I sensitive to their concerns? Do I give appropriate feedback to encourage healthful behavior change? And one of the things you can do is take a look around and just make sure, this is something that patients will talk about a lot, of feeling uncomfortable in treatment settings simply because of the basic equipment. There was a video that they have that was so sad, that kind of went through a bunch of situations that showed how it's something you'd never even think about, like the gown. You know, the gown, they show a video of a woman putting on the regular gown at her doctor's appointment, and it's just, it doesn't fit, and it's, you know, really makes her not want to be there. So those are important things to think about. And just to take away this thought after if you're working with folks who are overweight, how do my patients with obesity feel when they leave my office? So, review, and then we have a couple minutes for questions. Just the obvious, they're distinct but important overlaps between these two fields. Prevention and treatment programs will benefit more and more from cross-pollination, I think. Including weight loss as a treatment target is appropriate for many. Defining dieting and setting expectations about weight loss versus not losing weight is critical. Integrated treatment groups have potential, whether you're opting to have them or you're defaulting into them because you can't help it sometimes. And that weight stigma is widespread, and each of us can make a difference in reducing it or making one person feel better about their weight. Thank you. Any questions? I'm sure everyone's eager to go. I've been sitting a long time. Any questions? Yes.
So you know, what we hear most is that, that it's triggered.
Right.
And then you could have groups in this.
Right. Well, so when you say it's triggering, that you're basically telling me that I'm doing an exposure, right? So it may be triggering, but so is getting on the scale and seeing their weight, and we introduced that for FBT, and that works well. So is telling them they have to eat ice cream. So we end up avoiding things that people say are triggering, but if it's triggering, it ultimately would be a great thing for people to work through.
So the other side of that is that, just like you showed you talked about not having the right equipment in the office. So I don't feel comfortable because the program is geared mainly towards people with anorexia.
Yeah. I don't think you have a choice about that except to tell people up front, right? It's just the nature of healthcare. You can't start a program for 2 people. You could, but you do. But yes, but there are going to be situations where they end up in a group by choice or not. If they know up front they're going to be in a mixed group, then they know. I think the only thing is just upfront disclosure about that.
That piece of your discussion really provocative, because I do have a bias that I would prefer not to have.
Right, to have them separate.
But then I was challenging my own thinking, because I was thinking about the patients that I see so often will speak to their reluctance in going to a because they feel like they're
Mm-hmm.
I'm not finished.
Mm-hmm.
I'm going to stick out.
Right.
And so, in a way, it speaks to this continuum.
Right.
It still is the same force.
Right. I go back to that, the putting them both on the same side of the dumbbell. Yeah.
It seems to me that the issue is if it's an impediment to coming to treatment, then you have a big problem.
Yes. Yes, chime in.
We've actually had patients come into our program for BED who said how much they value being in a mixed group because it really breaks through this bubble that my problems will all be solved once I lose weight. And when we introduced, we started out having them all combined and then split out the binge IOP, and they're like, but wait, we don't want to divide for all the groups. And we've actually had patients on both sides really say, no, this is really valuable for all of us.
And I wonder if one thing to think about, would be having some groups mixed and some separate, right? Because there's going to be some issues that might be talking about body shame. Maybe you don't want to do that in a mixed group. But there's certainly things that where you could work on them together.
And of course we have the patients that she was talking about this morning who are in bigger bodies but restricted.
Right.
So that sort of breaks down all of those.
The differences, yeah.
Can I just jump in there? Because we used to have groups with anorexia, bulimia, and binge eating disorder, and our patients with binge eating disorder were so angry and kind of volatile, and they were just very verbally aggressive to our anorexic patients to the point that we had to start separating the groups. So we had a small, but we could not figure out how to integrate them together. And so the patients that had anorexia, for the most part, were very apologetic and tried to be nice and good. And then our binge eating disorder patients were just so angry,
That's so interesting.
yelling at them.
That's interesting.
It was fascinating, but it was kind of sad because we weren't able to fix it.
It may have been that group of people in part, but maybe that's that anger she was talking about is coming out. Maybe that's good. Not for the other kids. Any other questions? Should all go home. Get out of your chairs.
Thank you very much for spending the day with us, and I certainly have enjoyed being with all of you. Hope to see you again next year. Take care and have a great evening.